Dear colleagues, dear friends, welcome to this webinar, which will be focused on the risk stratification for non-muscle invasive bladder cancer and the treatment decision that will follow based on this stratification. And this evening, we will have a panel of 3 urologists. Myself, my name is Gontero, and I'm a urologist at the University of Torino, Italy. And I will discuss the implication for the high and very high risk disease stratification based on these tools that will be addressed by Bas van Rhijn, which is a urologist at the Netherlands Cancer Institute. And is actually the father of the new classification that was just recently published, together with Professor Sylvester, who has really devoted great insights in this stratification. And finally, Hugh Mostafid from the Royal Surrey Hospital in Guildford, who has just come out from theatre, will discuss the implication for treatment for low and intermediate risk based on the tumor stratification. We will have 1 hour. Each lecture will be between 10 and 15 minutes, and there will be the possibility to for you to address questions via your option of question and answers. And we will try to address as many questions as possible, although we have to finish by 7:30 Central European time. So it will be 1 hour. I hope it will be very fruitful. I would like to thank very much the EAU for this opportunity. And I would like to thank very much the guidelines for non-muscle invasive bladder cancer and upper tract tumor, and particularly Professor Marco B.W.G, who did this very interesting program. Thank you very much and enjoy our webinar. And now I give the podium to Bas van Rhijn, who will discuss the risk models and patient stratification in non-muscle invasive bladder cancer based on the EAU recommendation. Thank you very much, Bas.
So thank you, Paolo. Here you can see the slides I already have, and I would like to echo your words to thank the program committee of the EAU guidelines, and also the ESU, who is taking care of all this. And well, let's start with my part on this. So how did these risk models and patient stratification in non-muscle invasive bladder cancer come together? And at the end, I'll also have some EAU recommendations. First of all, here are my disclosures. Two advisory boards. And now I have to. Okay, there is the first slide. This is really a very short introduction to the to non-muscle invasive bladder cancer as a disease, and also why these models are important. First of all, non-muscle invasive bladder cancer is a heterogeneous disease. The recurrence probability at 5 years varies between 30 and 80%. And the progression varies between less than 1% and 45%. So there are multiple significant variables that predict recurrence and progression, and these variables have different weights for a certain endpoint, the endpoint being recurrence or progression. Well, mostly these variables are multiplicity, so one or more tumors, age of the patient, stage, Ta or T1, prior recurrence, CIS, grade, size, and gender. So when you mix these variables, then you can predict maybe individual risks for recurrence and progression for a patient with non-muscle invasive bladder cancer. And there are 4 tools available and explained in the guidelines, it's chapter 6, who do so. So the first one is the one by the EORTC in 2006. That's the basis for these risk stratification tools. Then there is one from CUETO, the Spanish Uro-Oncology group, published in 2009. Again, EORTC published the second one in 2016. And as Paolo already said, with the EAU Guidelines Committee, we published the 4th one, and that is published in 2021. And in the next slides, I'll take the opportunity to explain these 4 classifications. Well, the first one, the EORTC 2006. The paper was published in European Urology in 2006. In that cohort, there were more than 2,000 patients, 2,596. 54% of them were primary tumors. So primary means first diagnosis. There were patients from the individual patient data from 7 EORTC trials, and they were combined into one database. However, as you can see, the patients were rather from an old date. So the studies, the EORTC studies, were from 1979 to 1998. So a number of years ago. Well, the significant variables for recurrence and progression are the following. For recurrence, multiplicity, size, and prior recurrence rate are the most important ones. And the other significant variables are stage, CIS, and grade. And grade is the WHO 1973 classification system. For progression, it is the other way around. Stage, CIS, and grade are the most important significant variables, followed by multiplicity, size, and prior recurrence. And if you now look in the table, you can see what I just explained you. For recurrence, tumor size and also the number of tumors has a high weight, so a lot of points, so 6 for multiple tumors. And also with a high prior recurrence rate, 4 points. However, you see that for recurrence, grade only has 1 or 2 points. If we now go to progression, you see that grade, especially grade 3 disease, has 5 points. So that is a lot of points. So this means that grade is very important for progression, but less important for recurrence. These numbers were kind of, put together and in an online tool. And that online tool can calculate individual risks for recurrence and progression based on these 6 variables. And you see the internet address here. It's still available. And in the EAU guideline, as of 2009, we made different risk groups based on these scores. Low, intermediate, and high risk for recurrence and also for progression, based on these recurrence and progression scores. However, the treatment of these patients was mostly intravesical chemotherapy, and only 6% received B.W.G. It's important to notice this when we go to the next study. So the evidence summary that still is in the guidelines, the version of 2022, is that the 2006 EORTC scoring model and risk tables predict the short and long-term risk of disease recurrence and progression in individual patients using the old 1973 classification system for grade. If we now go to the next one, that is the CUETO study. Here it is. The CUETO study was published in the Journal of Urology in 2009. There were a little bit more than 1,000 patients. 2/3 of them was primary first diagnosis. It was individual patient data from 4 trials of the CUETO, and the time frame, so they are more recent than the EORTC 2006, is from 1990 to 1999. And again, significant variables in multivariable analysis for recurrence were gender, age, multiplicity, prior recurrence, CIS, and the old classification system for grade. For progression, age, stage, multiplicity, prior recurrence, CIS, and grade were prognostic. So, and in the table more or less resembles the table that you just saw with the EORTC score. You see the same thing happening. For example, the grade is very important for progression. 6 points out of the 14. And for recurrence, prior recurrence is very important, a high number of points. So the CUETO basically they did the same thing as the EORTC did. Based on these scores, they made their own risk calculator. If we now go to the treatment of these patients, well, these 1,062 patients all had BCG induction and short maintenance within these trials. In total, they had 9 to 12 installations. So it's not a real long maintenance as we know, so it's short maintenance for 5 or 6 months. If we now compare the CUETO with the EORTC 2006 model, first of all, CUETO confirmed the prognostic value of the EORTC 2006 model. However, they did find a lower risk of recurrence than in the EORTC 2006 model. So that raised the question, is it the BCG that lowered the recurrence? And for progression, again, a lower risk in high-risk CUETO patients. So probably because of BCG. So if we now have the evidence summary of our guidelines in 2022, in the patients treated with 5 to 6 months of BCG, the CUETO scoring model predicts the short and long-term risks of disease recurrence and progression using the WHO 1973 classification system for grade. We now go to the third one. The third one is the EORTC 2016. That is a more recent meta-analysis of 2 EORTC trials. 1,800 patients, and a little over half were primary first diagnosis. The time frame 1992 to 2005, and the paper was published in 2016. The significant variables for recurrence were multiplicity and prior recurrence. And the significant variables in multivariable analysis for progression were stage and grade. If you now look at the curves that are there, for recurrence, you see that multiplicity and prior recurrence was combined, and then there were 4 groups. They did the same for progression, where they combined stage and grade. The treatment in these patients was BCG induction and 1 to 3 years of maintenance. So the minimum planned number of installations was 15. However, mainly due to inefficacy, so patients progressing or patients recurring, 40% had less than a year BCG. If we now compare the CUETO with the EORTC, who are both studies that used BCG in them, the first thing to notice is CIS was not allowed in the EORTC 2016. However, the EORTC 2016 confirmed the prognostic value of the 2 earlier models, so of the CUETO and the EORTC 2006. And the risk of progression was lower for high-risk EORTC patients, probably because they received more BCG than in the CUETO group, in the CUETO paper. So the evidence summary in our guidelines of 2022, in the patients receiving at least 1 year BCG, prior recurrence and multiplicity predict recurrence, and stage and grade predict progression. And the identification of really high-risk patients remains difficult and an unmet clinical need. And that will be addressed in the EAU 2021. Sorry. If you now go to this paper that was published last year, this is the largest one. So there are 3,401 cases in there. All of them are primary, first diagnosis, and it's individual patient data from 70 centers in Europe and 1 in Canada. The new thing here is that it's not only the old classification for grade that is well researched, but also the new one, the 2004-16 classification system for grade. And the time frame is between 1990 and 2018. However, more than 50% of cases are from after 2010. We did not study recurrence here, but we only studied progression. And progression was significant for the following variables: stage, CIS, the grade 1973, but also grade 2004-16, the size, multiplicity, and age. This is, up until now, the only available model that also uses the new classification system for grade. We did exclude a lot of patients, and I'll explain you why. We excluded, of the more than 5,000 patients that we have in this database, we excluded 1,529 of them because they were treated with BCG. And BCG impacted progression. So BCG impacted our endpoint and is therefore a profound confounder. So we first have to make this classification system, and then later we can maybe validate it with our BCG patients. The grade in the primary non-muscle invasive bladder cancers was not prognostic for recurrence. So we advise, also via the guidelines, to use the other 3 models for recurrence. We were able to compile 4 risk groups for progression: low, intermediate, high, and very high risk. I'll show you in the next slide. The other thing that we added was literature data for factors where the individual patient data were not collected. For example, variant histology. If it was micropapillary, neuroendocrine, plasmacytoid, or sarcomatoid, it was considered very high risk. And the same is for lymphovascular invasion and CIS in the prostatic urethra. Primary cyst was not studied in this database. However, based on literature, we believe that high risk is the place where it should be. So it's CIS without any papillary tumor. And recurrent tumors can be classified as intermediate, high risk, or very high risk according to the other prognostic factors, as is also done in the other classification systems. Here you can see that actually more or less the same was done. On the left-hand side, you see table number 3 out of the paper, where you see that we have for the WHO 2004 and also for WHO 1973 calculated the weights, the same as was done in the first EORTC paper. What you can also see is that, for example, the grade 3 is a lot of points. It's 100 of the 317 points if you are grade 3. For example, for high grade, it's only 85 of 435. You can also see that the other variables are a bit less, have a little bit less weight in the old system than in the new system. Then this weight scores, they end up in the probabilities of progression. And the probabilities of progression, especially for 5 years, are interesting. If you now look, and the arrows are here, to the very high risk group, 40% probability of progression at 5 years, and 44% with the old classification system for grade. And if we compare this to the previous EORTC risk grouping, we only had low, intermediate, and high risk, and you see it was only 12%. So we have now created with this new system a very high risk group with a very high risk of progression, which was an unmet clinical need. However, we must emphasize that these patients did not have BCG. So if we now go to the evidence summary in our guidelines, that the EAU 2021 model predicts the short and long-term risk of progression in individual patients with primary non-muscle invasive bladder cancer using the WHO 1973 or the new classification system from 2004-16. You can use one of them or both. And now I'll have an example for you how you can very easily calculate the recurrence and progression risks, or the progression risk, because recurrence is not there. I'm sorry. If you, I took an example of a patient that was young, primary tumor, multiple tumors in the bladder, small tumors. It was TA, no CIS, and the grading was low grade, grade 1. And then, of course, if you click on calculate, then it gives you here the probabilities of recurrence, the probabilities of progression at 5 years, which is based on the new classification system, almost 1%, and 0.5% based on the WHO 1973 classification system. There are some disclaimers. First of all, PUN basically does not exist anymore. It's another story that we have from the EAU guidelines. So we have combined it with low grade because the PUN cases that we had the same prognosis as TA low grade. Then another thing, if you have both the 1973 and 2004 classification available, then preferably use the old classification, because when we compared these two classifications head to head, we found that the WHO provided better prognostic info. And then, as a last one, as I already told you, the 1,529 BCG patients, we are analyzing them. We are currently analyzing them, and probably they will generate some lower risks than the very high risk that we now found. But that will be at the EAU conference and probably a publication at the end of this year or next year. But we are still busy with that. So then I'll come to the EAU recommendations that you can find in Chapter 6 of the 2022 guideline. So stratify the patients into 4 risk groups according to the EAU 2021. Patient risk group can be determined using the calculator. And the calculator is on the internet, but also available on an app. For information about the risk of disease progression in primary Ta-T1 tumors, not treated with BCG, that's very important. You can use the data from this calculator. And you can use the old scoring model 2006 to predict the risk of tumor recurrence in individual patients not treated with BCG. And there are 2 other models, the EORTC 2016 for 1 to 3 years maintenance, and the CUETO model for 5 to 6 months of maintenance with BCG to predict the recurrence in individual patients treated with BCG. And how all these models translate into clinical practice will be shown by my 2 colleagues in the next talks of this webinar. So you can find everything in Chapter 6, and this is a little advertisement for our new guidelines book that is available online. I'd like to thank you all very much for your attention.
Thank you very much, Bas, for your clear and insightful talk. And I think we need to move on, but there is a question that came from the attendees, and the question is that one asked that it would be much more interested to have risk stratification after BCG treatment. So the 2021 for progression after BCG, a kind of CUETO or EORTC 2016. What is your opinion about that?
Yeah, I think we will have that because we had to exclude so many patients on forehand because BCG impacted progression. So my guess is that BCG does something with progression. It's the same as the EORTC 2016 and the CUETO found. So probably we will find the same, and then we may have to adapt the percentages of the probabilities of progression at 5 years a little bit. So, but we'll see. It's still research ongoing, and it makes it very lively, everything. And I think next year we'll know more.
So for the time being, either the CUETO or the EORTC 2016 can be used in clinical practice, and this is what the guidelines recommend.
Yeah.
If somebody wants to know, to discuss with the patient what is going to be the prognosis after BCG. Okay, thank you very much, Bas. I will come to you later. And now, Hugo, are you ready for your talk?
Yeah.
Mostafid will discuss now how we can use these risk models to decide the treatment for low or intermediate risk non-muscle invasive bladder cancer.
Thank you, Paolo, and thank you for asking me to speak. So I'm going to speak to you about risk-related treatment in low and intermediate risk tumors. So let's just move the slide. Okay, so these are my disclosures. And as Bas just explained, probably one practical thing, if you don't already have this, is to go onto your phone's app store and look for the EAU non-muscle invasive bladder cancer risk calculator and download it for free. And if you do that, it's actually very easy to put individual patients into their correct risk group category. So what you can see here is an example of a patient that I've picked. And on the first screen, you'll see that you put in all the criteria, such as the number of tumors, the tumor diameter, press calculate, and you can see on the second screenshot that it gives you not just the numerical percentages of the probability of progression, but also puts them into the correct risk group. So in this particular case, this patient is low risk. So moving on to the low risk group, this is what the guidelines use to categorize it. And if you don't have the app available, it's probably also important to try and keep in your head what kind of patient characteristics are typical of a low-risk patient. So in the EAU guidelines, a low-risk patient is a patient with a primary tumor. In this particular example, it's a single tumor that's Ta or T1, low grade, G1, less than 3 centimeters in diameter. But it can also have one of these additional characteristics that you can see up here. And those are age more than 70, multiple papillary tumors, or a tumor diameter greater than 3 centimeters. So if you put all of those together, this is, again, the probabilities of low-risk tumors. You'll see that overall, as we all know, the risk of progression with low-risk patients is actually relatively low. So, for example, at 5 years, the risk of progression is less than 1%. And so what we're really focusing on is correctly managing these patients, primarily to try and keep their recurrences down to a minimum, because we're not so concerned about their progression rate. We know that is going to be very low. So if we move on to what the options would be, this is what the EAU guidelines recommend for low-risk patients. So the overarching treatment option for patients with low-risk disease is a single installation of intravesical chemotherapy after the patient's TURB. And we know that there's very strong evidence, level 1 evidence, that this will reduce the recurrence rate. And indeed, this is a very nice summary of that. A single installation reduces the risk of recurrence and is considered to be standard and complete treatment. So complete treatment, I think, is the important word, which says that basically this is all you need to do for the low-risk patients. Now, in the EAU guidelines this year, there is a new section relating to chemoablation. And chemoablation refers to giving patients a variable number of installations of usually mitomycin, and importantly, before the patient has their TURBT. So the intention is that it's the chemotherapy that is the agent that ablates the tumors, not the surgery. And there have been 3 different trials that have come out, and because of these trials that were randomized, the EAU have this year included chemoablation as an option for low-risk patients. And I just want to review some of the data from these trials. So these trials involve giving patients between 4 to 6 installations of mitomycin. The trial that we did in the UK had a 37% complete response, but I would stress that this was based on patients having to have biopsy-proven complete response. If you look at the results of the other 2 trials, which used visual complete response, which is probably what we would use in day-to-day clinical practice, in other words, we'd look inside and we would say, well, the tumor isn't there anymore. You have a 60% complete response with 4 to 6 installations of mitomycin. All of these trials showed a very high compliance rate, which I think is important, bearing in mind that we know that compliance with a single installation after TURBT is relatively low, despite the strong evidence for it. The mitomycin was very well tolerated, possibly because the patient has not had surgery yet. And when you follow these patients up for afterwards, you'll find that the patients that respond to chemoablation have an identical 12-month recurrence-free survival to surgery, which is 84%. So they have very similar outcomes to surgery. And so this is really quite a good option for a selected group of patients with low-risk disease, frail patients, patients who don't tolerate surgery particularly well. And it's included in the EAU guidelines this year. One other option, which I think is worth discussing, because it's already common in prostate cancer and renal cancer, is active surveillance. And I think that low-risk non-muscle invasive bladder cancer and possibly even some types of intermediate risk are ideal for active surveillance. This is a summary of all this published series of active surveillance. And what you can see is that after a mean period of approximately 18 months, there is a very reasonable progression rate of less than 1%. And I think, again, this would be worth considering in patients who are rather elderly or frail as a treatment option for low-risk patients. So what about the intermediate risk patients? I've always found it interesting that this definition is almost a definition of kind of exclusion. It says effectively patients are intermediate risk because they're not low risk and they're not high risk, which is quite an interesting way to define a group. But I think if you look at these additional risk factors, a different way to think of patients that are intermediate risk is, if you remember, the patients who are low risk were allowed to have one of these risk factors. And Professor Gontero will probably come on to the fact that if you're high risk, you have to have all, or you can have all three of those risk factors. So the intermediate risk patients can also be defined by having two of these risk factors: age greater than 70, multiple papillary tumors, or multiple large tumors. I think the other way of thinking about tumors in a clinical setting as to whether they're intermediate risk is that almost by definition, any patient who started off being low risk and who recurs is going to be moving into the intermediate risk category. So what are the options for patients with intermediate risk? Just going to move on. Excuse me, yeah. So again, in the intermediate risk category patients, you can see that the risk of progression is starting to go up. For example, at 5 years, it's just under 5%. But overall, the risk of progression is still not that high. And so once again, our focus is primarily to try and keep the recurrence rate down as far as possible. And here we have two options. One is intravesical chemotherapy with a induction course of chemotherapy. And then the other one is treatment with BCG. So both of these options are equally valid in the intermediate risk group. However, as I'm going to show, so in the EAU guidelines, this is a summary of the recommendations that 1 year full dose BCG treatment, so it's a relatively short period of maintenance for 12 months, or installations of chemotherapy are both options in the intermediate risk group. But I think what we have to do is to temper that with the knowledge that most of us will be in situations where we're experiencing BCG shortage. And I think you'd all agree that at times of BCG shortage, the BCG that we do have should be reserved for patients with high risk disease. And therefore, I think that it's a relatively straightforward decision that patients in the intermediate risk group should probably be offered an induction course of intravesical chemotherapy. What's interesting is that there is also a suggestion that the chemotherapy could be continued for a maximum of 1 year, although no one really knows what the optimal schedule for such a maintenance course of chemotherapy would be. And then really just looking at some other options. This is now quite an old trial by Friedrich, where they showed that monthly mitomycin installations was as effective as a course of BCG. But this study did involve giving patients monthly mitomycin for a total of 3 years. And I think many people would feel that 3 years of monthly mitomycin is really quite an intensive schedule. But interestingly, this paper came out in 2007. And since then, there have not been any other trials looking at maintenance intravesical chemotherapy. One new possible option on the horizon is whether hypothermic mitomycin might have better results in this intermediate risk group of patients compared to mitomycin on its own. And the HIVEC-2 trial has completed recruitment, and we're very eagerly awaiting the results of that particular study. So that, in a nutshell, is the clinical management of low and intermediate risk patients. So happy to answer any questions.
Thank you very much, Hug. It was really very clear and practical talk, and I think all have enjoyed really your lecture. I probably think that for the sake of time, we should move on, but I know that you have to rush back in theater. There was one question, I think it's more related to intermediate risk, asking whether 1/3 BCG would be okay as compared to full dose. What is the view for intermediate risk when you use BCG, Hug?
Yeah, so Ashish Kamat did a very nice paper where they measured the number of colony-forming units in 1/3 installation compared to full dose installation. And there is such a wide range of colony-forming units in BCG that there was some overlap between 1/3 dose and a full dose. So I think there's fairly good evidence that 1/3 dose is actually, has an adequate dose of colony-forming units. We know from clinical studies that 1/3 dose patients seem to do almost as well as full dose patients. So I think that 1/3 dose could be an option for intermediate risk patients at times of BCG shortage, if you can get around the practical difficulties of splitting the vial into 3 doses.
Just quickly, Hug, another question. When you do chemoablation, somebody is asking why you don't do the 2-RBT. How do you know it's a low-risk disease?
Well, most of these studies were based on patients who were low risk already, and then they had a recurrence, and then you chemoablated their recurrence. So in effect, the patients were already known to be low risk with a recurrence. And as we saw from those risk calculators, we know that these patients have an extremely low level of progression. And so I think it was a reasonable assumption to say that when they recurred, it was safe to give them chemoablation.
Thank you very much. Unfortunately, we cannot address other questions that were related to you, Hug, and we need to move on. Thank you very much. And for all of you who are listening, please go to the question and answer, because Professor Sylvester has just reported where you can download the app for the new classification system. And now we move to the last talk. Okay. And basically, how do we decide the treatment for the high risk and very high risk category of patient? Here are my disclosures. For the high risk category of non-muscle invasive bladder cancer, based on the old stratification, I think that the new classification 2021 is the best tool that you should use in clinical practice, because it addresses the risk of progression, which is the most important endpoint in these disease categories, but also because it allows a more individualized classification of the patient that is based on prognostic factors. So we can divide the patient, unlike the previous categorization, into high risk and very high risk. And if we take the T1 G3, which is usually considered the worst non-muscle invasive bladder cancer, well, and you use the app, you see that you can define a not too bad T1 G3 if a patient is younger than 70 years old as a solitary tumor, small, less than 3 centimeters, and there's no concomitant CIS, because this kind of patient will be categorized as being at high risk of progression, with a probability of 11% to progress at 5 years. So this is reasonable. How should we treat this patient? Well, the guidelines suggest that a high-risk tumor should receive BCG as primary treatment option. Although radical cystectomy can also be discussed, taking into account the higher morbidity and the detrimental effect on quality of life. Why BCG? BCG has been shown to be the most powerful intravesical treatment as compared to mitomycin, and we have 5 meta-analyses showing this. It was also shown in 2 meta-analyses that it may reduce the progression rate, although other 2 meta-analyses failed to prove this fact. But we have to keep in mind that it's key for BCG being effective to be given with maintenance. And here you can see in one of these meta-analyses that if you give maintenance BCG, there is an advantage over mitomycin for progression, whereas this advantage is lost. There is no difference if maintenance is not given. How much maintenance? Usually the minimum maintenance is 1 year at a full dose, but although you could use also 1/3 dose. But when you have a high-risk disease, maintenance should be ideally given for up to 3 years to have optimal efficacy. Why giving BCG and not cystectomy in a high-risk non-muscle invasive bladder cancer? Well, BCG in a broad series of non-muscle of T1, T3 proved to be effective with a cancer-specific survival at 10 years of 85%, a progression rate of 21%, and 75% of the patient able to keep their bladder. But if we look at a large series of cystectomy for pathological T1 disease, you will find that 20% of the patient will have recurrence, and recurrence after cystectomy is a very bad prognostic factor, meaning that cystectomy is not able to cure all patients, even with the T1, T3, and so we basically do not have any proof that upfront cystectomy is superior to BCG. But in real life, when we have a T1 disease, we have to do a REACH-UR, and this is recommended for any T1 disease by our guidance. And so the question is, does the pathology at the REACH-UR may affect the treatment decision? Well, partly yes. The best scenario is when we do not have any residual disease, and this happens unfortunately only in 30 to 40% of cases, because the risk of progression is only 14%. If we have persistent T1 disease after REACH-UR, there is a 25% risk of progression. In these cases, the patient should be counseled between BCG and the risk related to BCG, and cystectomy may also be called into question. But we do have some patients that do not tolerate BCG, or patients that cannot receive BCG because of shortage. And the question is device-assisted mitomycin an alternative to BCG in high-risk non-muscle invasive bladder cancer? Well, the answer is yes. Either radiofrequency heating or conductive heating have both been shown to be equivalent to BCG in 4 small randomized controlled studies. Also, electromotive drug administration of mitomycin has been shown to be equivalent to BCG in a non-randomized series of high-risk non-muscle invasive bladder cancer. So, device-assisted mitomycin is an alternative to BCG when BCG is not available, or when the patient cannot tolerate the BCG for high-risk non-muscle invasive bladder cancer. What about primary CIS? This was not included in the in the recent risk stratification because it was an exclusion criteria, but primary CIS has long been considered as a high risk non-muscle invasive bladder cancer, and the guidelines recommend to still consider this disease as high risk. And the reason for that is because the response rate to BCG is very high, a complete response rate of 70%, which is maintained in a significant proportion of patients. So BCG with maintenance, with at least 3 years if possible, is the primary recommended treatment option for pure CIS. But if you have a T1 grade 3 with bad prognostic factors, that is a patient that is more than 70-year-old, multiple tumors or large tumors, or even a concomitant CIS, this patient will be categorized at very high risk of progression, with a progression risk of 44% at 5 years. And then, in this kind of patient, the guidelines recommend that the primary treatment option is represented by radical cystectomy. Of course, we do have patients that are not fit for cystectomy or patient who refuses cystectomy. In this case, as an alternative, BCG for up to 3 years of maintenance at a full dose could be a reasonable option. But radical cystectomy is the first treatment option. Why upfront cystectomy? Well, you take this institutional study, patients who had a T1G3 with at least 2 risk factors, that was multifocal disease, a disease larger than 3 centimeters, or concomitant CIS. In this patient, when cystectomy was deferred by 1 year, an average of 1 year in favor of BCG, the cancer-specific survival was significantly reduced as compared to patients who had immediate cystectomy. But there is also another reason. The patients who progress with the T1 disease, who progress to muscle-invasive bladder cancer, they do have a poor prognosis than patients who have a de novo muscle-invasive bladder cancer. So we need to prevent progression of T1 disease as much as possible, because the prognosis can be worse. And there are also patient categories like variant histology or CIS of the prostatic urethra, which are not included in the latest category of non-muscle invasive bladder cancer. And these patients are to be considered as at very high risk of progression. Variant histology such as micropapillary tumor, squamous tumor, neuroendocrine variant have all been shown to have a poorer cancer-specific survival if they are treated with BCG. The best survival option for this patient is to have immediate cystectomy. And the same is for tumor of prostatic urethra, which in a series of T1G3 was associated, along with the female gender, to a higher risk at 3.5 as a ratio for progression. So these particular disease categories should be treated as very high risk non-muscle invasive bladder cancer. So in conclusion, if we have a high risk non-muscle invasive bladder cancer, the primary treatment option is BCG. And in this patient, you can include the so-called good T1G3, the T1G3 who has no bad prognostic factor. But if you have a very high risk non-muscle invasive bladder cancer, the primary treatment option is cystectomy. And in this group, you have to include the bad T1G3, the T1G3 with bad prognostic factor, multiple tumor associated with carcinoma in situ or large tumor. Obviously, for patients who are not fit for cystectomy or refuse cystectomy, then you can offer as a second-line option BCG at the full course for 3 years. I thank you very much for your attention, and I think that probably we can now have 5 more minutes for your questions. Bas, you are still online. Bas, can you hear me?
I can hear you.
I think we have 5 minutes for some questions. I've seen that you have addressed a few of these questions. Well, there is one question that I think is probably for me. Are you still offering 3 years maintenance BCG? Well, yes, for high risk tumor, we do offer a 3 years maintenance BCG, and there is a large randomized study showing that up to 50% of patients can tolerate BCG, can actually conclude the BCG course up to 3 years of maintenance. So it's something that it's a treatment that can be proposed to patients. And now we look through, maybe Bas, if you also want to look through the question that we have.
Yeah, I answered a lot of them. It's very kind of Richard to put the...
Yes, thank you very much, Richard. Timing of RETU-RBT, I just remember 4 to 6 weeks, although this unfortunately can be difficult in clinical practice due to the long waiting list, and recently we have been, the last 2 years, we have been facing worsening of this problem. Gemcitabine in place of epirubicin. Gemcitabine has actually been shown in a single installation with one randomized study saying that it was effective and another study saying that it was not effective, but it has also been shown as a second-line treatment for patients with BCG failures with good results. So gemcitabine is a reasonable option, although in intermediate risk, we do not have a head-to-head comparison with epirubicin or mitomycin. But personally, I use it in clinical practice. It's cheaper, and particularly in this moment where mitomycin is not anymore so available. And then I think systematic biopsies to evaluate the response to BCG, still mandatory at 3 and 6 months. Bas, you want to address this question?
Yeah. The biopsies, where is it?
Systematic biopsies, well, I think the multiple biopsies should be used anytime we do a RETUR, at the time of a RETUR, because they are absolutely important to detect concomitant CIS. And I want to remind that concomitant CIS can be found in up to 50% of high risk or very high risk non-muscle invasive bladder cancer.
Yeah, that's true. And that's also probably some of the other questions pertain to this. And I also think that the question on the 1 year BCG, a reasonable alternative to 3 years in times of shortage, I think that is indeed a very good. The EORTC trials, the 2 trials that were combined in 2016, they have addressed this, and 1 year is has a little bit less efficacy, but only a little bit less side effects. So it's a very reasonable alternative. Yeah.
There is a question addressing whether we are using tests, I believe, in place of urine cytology for monitoring non-muscle invasive bladder cancer, and I think this is an evolving field, and probably very soon some of these tests that have been used in the have been published recently will probably be employed in place of urine cytology, which unfortunately has rather disappointing results.
Yeah, I agree that urine markers are still not there, and but they are getting there. They are getting better. That is so. I expect in the next years that we will see some more, and we'll see some changes in the guidelines as well. But this does not pertain to the chapters 6 and 7. It's more chapter 5 of the guidelines. So maybe that's something for another webinar.
Do we need a GA cystoscopy and biopsy post BCG, or just a flexi is sufficient? How do you do in your practice, Bas?
Well, if there is CIS, then we give BCG and then we do biopsies. But if there is only a papillary tumor and we know that we have kind of excluded CIS, then I think a cysto is enough to see the papillary tumor. Yes or no? Yeah.
There was also a question regarding maintenance with chemotherapy. Unlike BCG, where maintenance is absolutely mandatory, we do not have firm data to support the maintenance for chemotherapy. So I think that an induction course, whether you want to use 6 or 8 instillation, would be enough. And we do not have enough data to support 1 year maintenance. I think we are just crossing the timeline for ending this webinar. And I really want to thank, first of all, you, Bas, and Hug, for your excellent presentation. I really enjoyed this meeting, and I hope also our numerous attendees also had the pleasure to enjoy this important for clinical practice recommendation that comes from the guidelines. And once again, thanks to the EAU for their support to the dissemination of guidelines. And have a nice evening. Bye-bye. Thank you.
Bye-bye.